Okay, why don't we move on? Our next speaker is Tim Rebbeck, who's a professor at the Center for Clinical Epidemiology at the University of Pennsylvania. Tim got his undergraduate degree at Northwestern and then went on for a science master's degree at Johns Hopkins Medical School in the field of epidemiology. And he received his PhD in human genetics and epidemiology and statistics at the University of Michigan. And after a postdoctoral position at Fox Chase, he then became an assistant associate and now full professor at the University of Pennsylvania. And Tim's going to talk about the risk in BRCA1. Tim Rebbeck.
Thank you very much. Thanks. I appreciate the invitation to come here and speak today and to present before some colleagues. I wanted to also say that I've spent the last few months here at the Institute during my sabbatical, and I wanted to thank all the people that have made it such a nice stay. I've really learned a lot. It's an amazing place. So what I want to do today is talk to you a little bit about more detail on what we discussed this morning in the panel discussion, and that is the role of epidemiology and genetics in better understanding cancer risk, cancer predisposition, and ultimately cancer prevention and treatment. And I'm going to use BRCA1 and BRCA2 as the paradigm for what I'm going to talk about, because it's really among the best understood and among the more common of the hereditary cancer syndromes that we know about right now. But I just wanted to say in the outset that I think that a lot of the principles that I'm going to raise for you today are things that could be applied to lots of different cancers, lots of different genetic syndromes or genetic predispositions. So if you have another genetic syndrome, another genetic susceptibility of interest, you could probably do a global search and replace for BRCA1 and breast cancer and do something with HMPCC and hereditary colorectal cancer or P16 and melanoma. There are a lot of principles here that I think are relevant. And the main point that I want to make is that, one that was made this morning again, is that when we have genetic information, it can be valuable, but really it is of greatest value when we can do something about that risk, when we can intervene, we can prevent risk of developing or dying from one of these cancers. And that genetic information, without that next step of translation of genetic information into a clinical prevention or a clinical treatment setting, is of less value. So let me just present to you some data that we have that suggest that BRCA1 and BRCA2 help us understand cancer, and the genetic testing, the use of that genetic information is valuable. So let me, as just a very brief bit of background, I think most of you are aware that BRCA1 and BRCA2 are involved in hereditary breast and ovarian cancer. And we've known a lot about hereditary breast cancer for quite a while. We've known since the mid-19th century, since the 1860s at least, when it was first described, that some families have more breast cancer than others, and some of this breast cancer appears to occur in a Mendelian fashion. So aggregation of breast cancer in families is well known. In the 1980s, some very powerful segregation analyses were undertaken that showed, in fact, a Mendelian pattern of inheritance of breast cancer, suggesting a gene or genes that might explain the patterns of cancer. In 1990, BRCA1 was linked to a region of the human genome, and in 1994, BRCA2 was also linked to another region of the human genome, and these genes were cloned in 1994 and 1995. So it took us 100 years or so to sort of come to the point that we understood that cancer is hereditary. Breast cancer, in fact, did run in families, and we could understand that hereditary component by cloning genes that were responsible for those patterns of disease. And it's really only since that time that we've been able to understand the biology and make clinical use of the information about genetics of BRCA1 and BRCA2. And that's where we are right now, and what I sort of want to focus on now that we have these genes. What do we do with them? What do we do with this information? We know already that BRCA1 mutations that cause aberrant protein function or structure can be associated with a risk of a number of different cancers. So we know, for example, it's associated with primary and secondary breast cancers, or second primary breast cancers, as well as ovarian cancers. And this is the hallmark of the syndrome of BRCA1. There are also suggestions of increased risk of other cancers, which are not as well characterized, but it suggests that the BRCA1 mutations don't just confer risk of breast and ovarian cancer, but other cancers. And so while it's pretty clear to you all that having this kind of mutation is deleterious and results in cancer, the first point that's important to note here is that it's not a simple situation. We don't have a one-to-one mapping relationship. You have the mutation, you inherit a mutation, and you will develop a cancer. You can see that the risk of breast cancer is 60 to 80%. There's a range. Same thing for second primary cancers, for ovarian cancers, and some variability in the cancer risk at other sites. So the first thing that we've learned, even though we started studying hereditary breast cancer and BRCA1 mutations, thinking that this was going to explain hereditary breast cancer, there is more going on. And that's a sort of a theme of the talk that I'd like to give to you in the coming slides. And similarly, we see the same thing in BRCA2. Germline mutations in BRCA2 are associated with an increased breast and ovarian cancer risk, as well as an increased risk of male breast cancer, which is really rare in the population, as well as a risk of other cancers at other sites. So similar to BRCA1, the risk isn't 100%. It's not a one-to-one mapping. There's variability in the phenotypes that are conferred by these mutations. And just to put a finer point on it, we have a lot of women in our collaborative studies who are 60, 70, 80 years old and have never been diagnosed with a breast or ovarian cancer, even though they carry one of these mutations. They seem to be resistant to developing cancer, despite the fact that they're supposedly at very high risk. And what does all this mean? How do we begin to tease that apart, given that we know that these are cancer genes? So what we know, at least from observational studies and the data that I'll present to you in a minute, that there's no simple relationship between the inheritance of one of these mutations and cancer risk. So the magic silver bullet of, oh, we're going to test somebody and we're going to know everything we need to know is not really quite true, that there is a lot more probably going on with respect to germline mutations and risk that we don't yet quite understand. And what are these factors that might explain this inter-individual variability in risk? And how can we use that information to reduce cancer risk and mortality in the people that carry these mutations? So these are the kind of questions I want to address for you today. And particularly, I'd like to present to you some data that ask, can we explain variability in cancer risk, the variability that I just talked to you about, so that we can improve our ability to predict risk in people, as well as hopefully provide some insight into the biology of BRCA1 and BRCA2. And secondly, can we modify this cancer risk? Can we do something to reduce risk and to reduce mortality, or the chances of dying of cancer if you have one of these mutations? So let me just go through these step by step and present to you some data. It's not going to be the encyclopedia of all data, but hopefully something representative that give you the sense that there are other things out there that modulate risk in women who carry these mutations. And the factors that we might consider as moderators, modifiers of BRCA1 associated or BRCA2 associated cancer risk include mutation location, the type of mutation that you actually have, other exposures, or genes at other loci. And I'll just present to you a little bit of data that we have so far about these factors, and then try to summarize what it is we really know about these. So the first thing that we've observed is that early on, after the cloning of these genes, BRCA1 and BRCA2, it was observed that some individuals who have mutations in a particular region of these genes had a different risk of ovarian versus breast cancer. And as you can see by some of the papers that were done by the large consortia, these papers are more than a decade old at this point, so we've had this observation in hand for quite a while. And the observation is that if individuals carry a mutation, they've inherited a mutation in the center, the middle portion of both BRCA1 and the BRCA2 genes, they seem to be at relatively increased risk of ovarian cancer relative to breast cancer. Now, it's not to say that there isn't breast cancer among women who have these mutations in these regions, but there is more ovarian cancer than you might have expected compared to if your mutation was sort of in the 5' or 3' regions of the genes. the regions are not completely well defined, and even after a decade, I don't think anybody knows what the biology of this observation is. We know now, for example, that mutations that arise in these genes often are not expressed because of nonsense-mediated decay of the mutant protein. The mutant protein is essentially not there in many cases, so it's not clear why a mutant protein that might not be expressed at all would have an effect, differently if the mutation was here or here at different parts of the gene. It's an observation that's pretty robust, but we have no idea biologically yet, as far as I know, what it actually means. And as a result, and because of some of the ambiguity, we really haven't used this information clinically, at least not to my knowledge, that anybody says, well, your mutation is here, you're probably at a little bit more increased risk of ovarian cancer. Don't think we know that yet, so it's a conundrum and an interesting area for future research. In addition to things like the mutations that you've inherited, you can imagine that there are also exposures that might influence people's risks. So just like you're aware in the general population, we have information that says reproductive history, other kinds of exposures that you might have had, diet, smoking, things like that might be associated with different breast cancer risk. We think that the same thing might be true in women who carry these mutations, and it's sort of what you'd expect. And so this is just a synopsis of some of the data that we have, and we know, for example, that high parity, having had a lot of children, should decrease risk, should protect you from breast cancer. The data so far, although I haven't shown all the papers up here on this slide, haven't really shown that, haven't supported that. And I guess that's one of the big themes of this kind of work, is that it's early. We don't know that these are the right answers yet. A lot of research needs to be done to understand the role of even simple things like how many children you've had in understanding the association with breast cancer risk. But to the degree that we can do that, we might be able to modulate or better understand risk assessment, risk and counseling of women based on knowledge of things like reproductive history. There are other things like breastfeeding or late age at first live birth, which in at least a couple of studies have been consistent with what we see in the rest of the population, but again, very early. One of the interesting and difficult things that multiple groups have observed is that cigarette smoking appears to be protective of breast cancer in BRCA1 and maybe BRCA2 mutation carriers. This is a little bit tricky. As you can imagine, we don't want to give anybody the message that it's okay to smoke. Obviously, what we think we may be seeing here, and it's been in 3 studies, even though this middle study, I have a 0 there because they didn't have a statistically significant reduction in risk, but it was about a 20-30% estimate of reduction, so it was in the same direction, suggests that maybe cigarette smoking depresses steroid hormones circulating or whatever that might be associated with diminished breast cancer risk. And so really we have to be careful about the public health message, but it might just be that we need to follow this up and understand the biological basis of this. We don't want people to smoke, but maybe we can create a pill or something else that will mimic the effect of smoking. But this actually appears to be robust in all the studies that have been published so far, and it's not clear exactly why. But it really lets us know that there probably are exposures and reproductive history and other factors that might be associated with modulating risk, and that's important, particularly if these things are modifiable. If a woman can do something diet-wise or take a pill that might influence these factors that we're observing epidemiologically. So while there's a lot more research to be done, this is the kind of direction that I think we can head to identify and introduce modifiable risk factors for risk reduction. Similarly, there are probably genes at other loci, and as Arnie Levine just spoke to you about, there are genes out there in populations that are probably associated with increased or decreased risk of various cancers. And by the same token, even though the background baseline risk among BRCA1 and 2 mutation carriers is very high, we can hypothesize that there are other genes at other loci, other variants that increase or decrease that risk around that high baseline. These are the kind of genes that you might think of as candidates, those involved in steroid hormone metabolism, in carcinogen metabolism, DNA damage and repair, or oncogenes. And there's a long list of these potential genes. And a number of these have been studied, and I won't go through the literature. Again, the literature is fairly early. A lot of the studies were not done well or with a great deal of power or well epidemiologically designed. But we're beginning to learn a little bit, and one of the things that we've begun to identify as a gene that's probably a modifier of risk, at least in BRCA2 mutation carriers, is RAD51. RAD51 is involved in the same DNA damage response recognition pathways as BRCA2. And so it is a good candidate for involvement in helping to protect or guard the pathways that might be damaged if a BRCA2 mutation was inherited. And what's been found is that a particular SNP in RAD51, in the 5' region of RAD51, was strongly, now in 3 studies, associated with an increased risk of breast cancer in BRCA2 mutation carriers. So this is something that's been replicated. It's biologically plausible, and I just put this up because the SIMBA consortium, which is the large, essentially worldwide consortium of BRCA1 and 2 mutation carriers, has just done an analysis of about 12,000 BRCA1 and 2 mutation carriers. And in BRCA2 mutation carriers, they've shown that the homozygote variant genotype confers about a 2-fold risk of increased cancer risk in BRCA2 mutation carriers, while the heterozygote confers no risk. So, a couple points. One is that there probably are modifier genes out there that modify the effect of BRCA1 or BRCA2. Early on, these studies sort of showed these humongous 3- to 5-fold increases in risk associated with these single SNPs, which seems unlikely. It seems unlikely that there's such a big effect of a single SNP. But that's what was reported. And often we see this winner's curse phenomenon of early studies showing these kinds of very large effects. But when the very large consortium comes together, does the analysis in a broader spectrum of better design and more people, we see that effect going down closer to 1, but in fact, of course, still being statistically significant and meaningful because it is doubling the risk of breast cancer in BRCA2 mutation carriers in this large consortium. So this is one example, at least, that there are probably modifiers of risk that are genetic in nature, and more that we'll need to identify as studies go forward. All right, so what I've just told you is that we might be able to start explaining this complex variability that we observe in risk of cancer among people who carry these BRCA1 and 2 mutations. And so, again, it's not just the mutation in BRCA1 or 2 that you've inherited that may matter. Other things come into play. And how do those come into play? We really still need a lot of work to understand, but we're beginning to do that. And so when you hear about people saying, well, we've cloned a gene, we found the gene for this, or we found the gene for that, what you can probably anticipate is that that's great. It might be true, and it might be useful, it might be clinically applied, but what's next? What else is there that we have to learn about the other factors that modulate that risk? And that's sort of the next wave, I think, of studies that will occur once we begin to identify the major cancer or other disease susceptibility genes. All right, so in part 2 of this, I'd like to talk about what do we do about this risk. So again, these women and men in some cases who have very high risks of cancer because they've inherited one of these mutations in BRCA1 or 2, they need to do something about that risk. It's at a level that the information is valuable and that they need to consider doing something about it. And what are those things that one can do in order to reduce risk reduction and mortality reduction? Well, there's a lot of proposed strategies or potential strategies one can consider. Clearly, there's cancer screening. You can imagine that for breast cancer, mammography or MRI screening could be quite valuable in the early detection of breast tumors. I'm not going to talk a lot about those, but there are studies that suggest that MRI might pick up kinds of cancers that mammography misses because MRI is more sensitive, particularly in the breasts of young women that are very dense. Having said that, there are situations in which mammography might be superior. For example, if you're looking at DCIS, ductal carcinomas in situ, which might not be picked up as well on an MRI, but the calcifications in those ductal carcinomas might be seen on mammography, there might be situations in which mammography might be superior. And that it might be true that you need both in some way. And I'm not going to talk a lot about that. There are studies going on to begin to address this. But the issues of screening for breast cancer are not entirely clear. And an additional point relative to mammography is that mammography is radiation exposure, and it can cause DNA damage, or in theory. And the question of concern that many women have, and that we don't really have a good answer to yet, is if you're giving women mammographies at a very early age, and perhaps more frequently than you would in a woman in the general population, but that woman has a damage to her DNA repair recognition capacity, what is going on? Are you actually going to increase risk back by doing these intense screening procedures using radiation? And the answer to that is also not clear, but these are issues that one needs to consider, even though I think mammography is something that is used and would be a standard in screening for most women. There are a lot of issues. When you come to ovarian cancer, it's much more difficult. CA125, a serum marker, and vaginal ultrasounds have been used, but have never been shown to be effective in reducing mortality from ovarian cancer. And really, there is no screening tool for ovarian cancer that's been shown to be effective in any setting. So ovarian cancer screening is difficult, problematic, and there isn't really an option for women, but yet they need to do something because they're at very high risk. Obviously, it would be nice to have some sort of chemopreventive agents, SERMs, oral contraceptives, estrogen modulation, estrogen receptor modulating kinds of agents that might influence the hormonal milieu that these women, that might be influencing these women's cancer risk. Right now, there aren't a lot of data to address this, and I'll present you a little bit of it in a second. The main approach that is used is surgical. Bilateral prophylactic oophorectomy, removing healthy ovaries before they become before a tumor arises, or bilateral prophylactic mastectomy, removing healthy breast tissue. And again, these are surgical, pretty radical interventions, but they are. I'll present you the data that suggests that they work. But can we do what are the issues that we need to think about in applying them? So let me just present to you a little bit of data suggesting some of what we know. It's not, and you'll get a sense of where the field is with respect to, well, now you have a mutation, what do you do? So one piece of data that we have relates to oral contraceptive use. Early on, in 1998 and 2001, there were two papers that suggested that, the first paper suggested that the use of oral contraceptives might reduce ovarian cancer risk by about half, and that's consistent with some of the literature, or maybe a lot of the literature, in the non-BRCA1 and 2 setting. A second paper from Israel found no such decrease in risk, but there are reasons that might explain why they didn't find that based on patterns of reproductive history and oral contraceptive use in that other population. So at least we have some sense that the use of oral contraceptives might be a chemopreventive agent, if you will, for ovarian cancer risk. And so that's nice to think about if it were, because oral contraceptives are readily available. There's something that people are familiar with. There's something that could be prescribed and used. If they were really chemopreventive, it wouldn't be like starting something, drastically different, or getting FDA approval for something. It's something that's there. But the questions started coming up later when a couple of studies started presenting data suggesting that breast cancer risk might be increased in women who used oral contraceptives and had BRCA1 or 2 mutations. In a very early study out of USC, there was a suggestion that women with BRCA1 mutations were at greater risk than women who didn't have those mutations. And a more recent study, 5 years ago now, suggesting a very small increase in risk of breast cancer among women who used oral contraceptives and carried BRCA1 or 2 mutations. So the problem with something simple, if you will, of oral contraceptives is that it's not a clean picture. Again, maybe there's some protection, maybe not, depending on what population you come from or your reproductive history, and maybe there's some breast cancer risk. And so the data have not been entirely clear, and so it's not so simple to say, okay, everybody go out and take oral contraceptives. That will be useful. And these become individualized decisions that women need to make with their clinicians. we also know that there are chemopreventive agents, drugs out there that might prevent breast cancer. We know, for example, that tamoxifen is one of those. Tamoxifen has been shown in a number of studies, in large studies and randomized trials, to reduce breast cancer risk, but there really isn't a lot of data in the BRCA1 and 2 carrier population. So, for example, there are some papers showing the effect of tamoxifen on contralateral breast cancer risk. That is, you've had an initial breast cancer diagnosis, you're given tamoxifen as part of your treatment to reduce the risk of having another tumor arise. And early on, Stephen Narod's group suggested that using tamoxifen gave you about a 50% reduction in contralateral breast cancer risk after a primary breast cancer diagnosis. And that's similar to what was seen in early trials of the same type. And more recently, the same group has shown that this is apparently so, although not quite so powerful in both BRCA1 and 2 mutation carriers, but interestingly, not the same if you've had your ovaries removed. Women who had their ovaries removed didn't see the same kind of protection of tamoxifen as women who had ovaries intact. So this leads us into the surgery discussion we'll have in a second. And I put these data up here, a paper in 2001 by Mary Claire King's group that actually analyzed the large NSABP trial for BRCA1 and 2 mutations, and essentially had only 19 people with mutations. And so there really isn't any data out there that help us to understand the primary prevention, the use of tamoxifen in primary prevention of breast cancer. So we really don't know, and obviously the more recent agents of, raloxifene or some of the others that are out there have not really been studied yet. So we don't have a lot of data on the use of chemopreventive agents, pills, or something else that might supplant surgery or other options as a way to prevent cancer in these very high-risk women. So what women are really left with, for the most part, is surgery. And so we have to ask the questions, does removing your breasts, both breasts prophylactically, reduce breast cancer risk? And does removing your ovaries prophylactically reduce ovarian cancer risk, which you'd sort of guess, or also breast cancer risk? Because when you remove ovarian hormones, you would hypothesize that breast cancer risk might also be reduced because that hormone exposure that might lead to breast cancer is gone. And so there's a lot of data now that suggests that this is the case. Here's some of it. We in a few studies, some early and small, and some a little later and still relatively small, but it's pretty clear that removing healthy breast tissue, before the diagnosis of a cancer, is associated with a large decrease in breast cancer risk, and you'd kind of guess that, right? It's not completely rocket science to think that if you're removing most breast tissue, you would reduce breast cancer risk. But the early studies were relatively small and didn't have enough data to say what that risk reduction was. We don't think it's complete risk reduction, and in this study that we did a couple of years ago, we made an estimate that the risk reduction was about 95%. But what that means is that there is residual risk, that women, even though they have a fairly intense surgical intervention that removes most of the breast tissue, there's still breast tissue left behind. There always is. It can't be removed completely, not all breast tissue, and so there is some residual risk even in women who choose these kinds of surgical interventions. So, but it works. It works for most people and pretty effectively. And I'm not going to talk about the psychosocial kinds of issues that are associated with it, but clearly having prophylactic mastectomy, particularly in very young women, is not a trivial thing. It's something that would need to be discussed and thought about very carefully by women who are thinking about undergoing these options. Similarly, we've learned that reducing ovarian or breast cancer risk after removing your ovaries seems to be effective as well. So ovarian cancer risk in 2 papers that I think set the standard for this work shows that ovarian cancer risk is substantially reduced after the removal of your ovaries. And again, you can say, well, if you took your ovaries out, why should there be any risk left over? But there is, and that was mentioned this morning, that there are residual cells in the peritoneum that are ovarian in origin that can become cancerous. And so even in women who've had ovaries removed, who have no evidence of cancer at the time of their surgery, there is some residual risk. And as you can see here, this risk is not trivial. So we say here a 95 or an 85% risk reduction. That still says that there are quite a few women who are diagnosed with a primary peritoneal cancer of ovarian origin after they've had their ovaries removed. So again, the risk reduction is not complete. It's great, it's large, but it's not complete. And that's something that's important in counseling to consider. Similarly, as we hypothesized, taking out your ovaries should remove the ovarian hormones that you're being exposed to and then reduce breast cancer risk. And in fact, in these same observational studies, this is what we see. We see that risk reduction is 50 to 60 to 70%, a large reduction in breast cancer risk after removal of ovaries prophylactically. And that's kind of, it makes sense that that would be the case, and it is what we see. So prophylactic oophorectomy, in the meantime, has become essentially a standard of care. I would say that it is recommended, not even just discussed, but recommended that women who are completing childbearing, who have completed their childbearing years, have their ovaries removed. Because since we can't screen for ovarian cancer, and we know that this surgery will remove most of the ovarian cancer risk and a lot of the breast cancer risk, that it's a reasonable thing to do. And I think most clinicians you would ask would say, yes, that's probably something women should always consider if they carry one of these mutations. But again, as you might have guessed from the theme of this talk, it's not quite so simple. There's a little bit more to think about. One of the things that's an issue is that women who are undergoing these surgeries, oophorectomies, are usually very young. So you're taking women who are otherwise premenopausal, and making them, through a surgery, postmenopausal. They've undergone a surgical menopause. And if menopause, the natural menopause, is not pretty sometimes with respect to symptoms and negative consequences to the individual, the surgical menopause is as much so, if not more. And so the question is, well, can women take hormone replacement therapy if they have had their ovaries removed and they're having menopausal symptoms? And clearly you're talking about women who are at very high risk of breast cancer, and you're all aware of the large studies that have shown that use of hormones, exogenous hormones, estrogen plus or minus progestins, et cetera, probably particularly estrogen plus progestins, is associated with increased breast cancer risk. So women are quite concerned that, can I take this? It's going to just take my breast cancer risk back to where I was. So we did published a study a couple years ago that suggested, compared to women who didn't undergo surgery and never took hormone replacement therapy, so sort of a no exposure group, women who just had an oophorectomy had the breast cancer risk that was something like what we estimated it to be, a substantial reduction in breast cancer risk, but that even women who had that oophorectomy and took any kind of HRT or progestin plus estrogens or estrogen only, still showed this remarkable effect of oophorectomy. And so at minimum what we can say is that the effect of oophorectomy is not negated by the use of HRT. Whether there is some residual increase in risk for using these HRTs is not entirely clear from the data that we have, but at least we can say that if you're worried about having to take HRTs after having the oophorectomy, it's okay. You can probably have the oophorectomy. If you need HRTs, you might be able to take them without worrying too much about the consequences with respect to breast cancer risk. Data are still a little bit early on this, but it's something that's encouraging, at least, because it gives women this option. The final question, or this piece, the last part of this is, well, what we're really worried about is dying. I mean, everybody is worried about developing cancer, but we really need to know, are these surgical interventions actually going to prevent you from dying of cancer? And so, again, this past year we published a study that suggested that mortality was in fact reduced. So compared to overall in all women in our study, the mortality was reduced by about 75% among women who'd had an oophorectomy. That is, it's sort of we call this sometimes the DUH study in a sense, because we're reducing ovarian cancer risk by 90% and breast cancer risk by 50%. We better be reducing mortality, because if we're not, what is going on? But of course, we do see that there's a substantial reduction in mortality among women who undergo these surgeries. And so it's an important clinical point that needs to be made to women, that having this surgery could keep them from dying of a cancer. Interestingly, when we look at breast cancer-specific or ovarian cancer-specific mortality, we see something, at least for the ovarian cancer-specific, we see a very strong, 90, 95% reduction in ovarian cancer-specific mortality, which is sort of similar to what we saw, that you're reducing risk about that much, and so you've reduced our mortality about that much. In breast cancer, it's a little different. We reduced breast cancer risk by 50, 60%, something like that. But we're reducing breast cancer-specific mortality by something like 90%, much greater than just the risk reduction. And we don't know exactly what that's due to, but we might be able to hypothesize that we're actually also treating breast cancers in the process. So we're removing ovarian hormones. So women who have breast tumors are essentially being treated for their breast tumor by having those hormones removed in some sense. And so that maybe the mortality reduction for breast cancer is even greater because of that hormonal removal and the effect it has on any tumors that are present at the time of the surgery or develop after the surgery. So it's very encouraging to think that by this kind of surgery, which is widely done and used, there is the ability to reduce mortality fairly substantially. So, just to conclude, we know that there are high penetrance genetic mutations in BRCA1 and 2 that are associated with very elevated risk. This is pretty well established. But it's also clear that other factors influence disease, mutation location, genes at other loci, exposures, not well understood, but there probably are these things. And I think that what the data have pointed us to, both in the epidemiological literature as well as in the surgery, the prevention literature, is evidence that hormonal modulation of BRCA1 and 2 associated cancer risks exists, that hormones are very important in BRCA1 and 2, just as they are in the regular non-BRCA1 and 2 breast cancer. But this is an area in which we'd want to pursue hormonal mediation, regulation, prevention, if we can. And I think that the take-home point in this, as we've said this morning in the panel, is that genetic testing for BRCA1 and 2 are justified because cancer risk and cancer mortality can be reduced. That is to say, we can test people, we can learn enough about them, and then intervene in them in order to keep them from dying. And so this is something where genetic information, genetic testing has become a standard of care, is useful and valuable, and in fact is something that we should probably promote to the degree that it's going to save lives. And I just want to say one thing at the end, that this is work that is being done by a very large number of investigators, a number of whom are in this room. Actually, Judy Garber, Laura Vanteveer, Mary Daly from Fox Chase. There are a number of people who are involved in this work. And because BRCA1 and 2 mutations are relatively rare in the general population, it's incredibly important that we have collaborative work that goes on among a lot of different investigators really around the world. And so I'm very grateful to them for their collaboration. Well, thank you very much. The site of action? Well, that's an interesting question. I don't know the answer to that. Does somebody in the audience know that? I mean, it works through estrogen receptors, but I mean, do you mean like the molecular targets in the breast cell? That I don't know the answer to. Does anybody? Somebody must know that.
I think one other question here.
Yeah. Yeah.
Stronger data in terms of endometrial cancer
Yes.
and cigarette smoking.
Yes.
And I would not like to discourage people from looking at that further. There are non-carcinogenic inducers of CYP1A1, 1A2, probably induced in target tissues
Right.
that could be preventive.
Right. No, I completely agree. And I mean, as we know, endometrial cancers are much more hormonally sensitive, steroid hormonally sensitive than breast tumors, at least epidemiologically. And the question of the mechanism of that is not entirely clear. If you obviously, steroid hormones are both mitogens and mutagens, and so the ability to induce factors that create catechoestrogens and mutagenic quantities certainly could could be playing a role there, but also metabolizing the mitogenic, the growth factor properties of estrogens play a role. And I don't think it's very well understood, but I agree it's important.
Many of the metabolites of estradiol are non-carcinogenic on
That's right.
breast.
Right, and so
So I think that you'd have to postulate a detoxification of
Right.
estradiol or it going through a non-carcinogenic pathway.
Right, so the activity of cigarette smoking inducing these enzymes, which then have the secondary effect of generating estrogen metabolites that may or may not be carcinogenic, is clearly one of the hypotheses that people pursue. Yeah.
Okay, thank you very much, Tim.